that can be used. Or another possible complication are injury of surrounding structures during opening or closure of the approach, including the internal mammary arteries, the right ventricle, or intra-abdominal contents, especially during tunneling for chest drains. The upper hemisternotomy is the most commonly performed access route for these operations. We like to look at the chest x-ray or a CT if we performed one before making our incision in order to see how long the aorta is. If the aorta is elongated, you definitely should open the sternum through the fourth intercostal space. If it's not elongated, then the third intercostal space is also possible. We like to start the skin incision from the sternomanubrium junction and then extend it 5 to 8 centimeters inferiorly. The incision be extended a little bit superiorly without any difficulties. We like to perform either an upper J or an inverted T. My preference is an inverted T in order to prevent any tilting of the thorax during the procedure. And I personally like to use the fourth intercostal space, although I know a lot of people go through the third intercostal space, and an oscillating saw is, from my point of view, the best way to open the sternum. As far as right mini thoracotomy access is concerned, you've already seen an excellent live in a box presentation from Fahad Bakhtiari. I won't say much about this because he's a real master of this technique, but there has been some papers written to describe how the aorta should be at least 50% to the right of midline, and it should be 10 centimeters away to the annulus from the incision point on the thorax. We don't pay too much attention to this, to be honest, and we think that most patients are candidates for this approach. This approach, what's important to note is that you almost always need to use special instruments, whereas for the upper hemisternotomy, you can usually use normal surgical instruments. Some special instruments that are quite helpful are a flexible aortic clamp for both types of procedures. There's multiple different companies that make these clamps and some that even detach from the holder. We like to use the minimal invasive tools, especially for the right anterolateral thoracotomy approach, but these are a bit shorter than the ones that we use for the minimal invasive mitral valve operations. And for the anterolateral thoracotomy, we always use a soft tissue retractor. This is very helpful. Venous cannulation options, you can cannulate right atrial appendage directly, especially through the upper hemisternotomy. It's uncomplicated, but the disadvantage is that the cannula lies in your surgical field the entire time. You can also do a subxiphoid tunnel and then cannulate the appendage so that the cannula is no longer in your field. But this is technically more challenging, and it's important to stay between the pericardium and the sternum in order to avoid injuring any surrounding structures. You can also directly cannulate the SVC. To be honest, I've never done this, but I know many people do. And then, of course, there's percutaneous femoral vein cannulation, which is really nice because you have no cannula in your field. However, there are, of course, complications associated with peripheral cannulation. And especially if there's any resistance while inserting the obturator, you have to be careful. Oftentimes, it's because the obturator is pushing the soft wire through the back wall of the vein, and therefore you have to switch to a super stiff wire to avoid problems. Left ventricular venting options. We usually use the right superior pulmonary vein, but it can be difficult if the chest is deep. You can also put a vent through the aortic valve. I personally do not like doing that. You can vent the pulmonary artery, which is a little bit less effective than the other techniques. Or another very good option that is easy to get to and gives you a good drainage is right through the roof of the left atrium, and you just simply put a stitch in it afterwards. We've published our experience with this, these operations. This one was 1,700 patients a few years ago, and we had a conversion to sternotomy rate of 0.3%. Of course, if there's an upper hemisternotomy approach, this is not a big problem because you do not have to make a new incision. We make sure we do not hand off the saw until the very end of the case. But the cases where we did have to convert were those where we had troubles seating the valve, where we had some coronary obstruction, or if we had markedly prolonged cross-clamp times or required a second cross-clamp in order to fix a leak, for example. Whereas the right thoracotomy approach, if you have to convert, it's a bit more painful because you do have to make a whole new incision. And certainly those patients that have inadequate exposure or prolonged ischemic times, this is a consideration. And for this reason, many people use the sutureless or rapid deployment valves for this approach. other catastrophic events that may lead to conversion are cardioplegia delivery problems, an obstructed coronary artery, difficulties with the aortotomy, or of course an aortic dissection, which is a rare but very, very dangerous complication. So in summary, minimal invasive aortic valve replacement can be performed safely and effectively with a low conversion rate. We suggest planning in advance to achieve adequate exposure. Conversion to sternotomy is not necessarily a failure and should be discussed with the patients preoperatively, and is certainly preferable to a mortality. Thank you very much.
Thank you, Dr. Borg. Thank you, Dr. Borg. We would now like to open it up to the attendees for discussion. A reminder to all attendees, please be sure you're typing your questions into the Q&A box inside your screen. And again, apologies from the ISMICS studio and staff regarding the technical difficulties in the audio. Marco, you want to start the discussion?
Yeah, sure, Tom. I have one question for Mattia Glauber. And so what is the role of sutureless valves in minute thoracotomy AVR? Is something that you really need to have it? Can you do it without? And then I have a question also from Joe Lamellas. What is the real benefit of a scope for a minute thoracotomy AVR? Mattia, you're muted.
Yes, thanks for the question. Surely we can do the same procedure with conventional sutured valves. It depends sometimes from the indication, younger age, bicuspid, or even annular size, where Perceval cannot obviously cover bigger sizes. But in many indications, it's something that speed up, facilitates, and surely also standardize. And this is one of the reasons why I honestly prefer this kind of device.
What about the benefit of a scope in minute thoracotomy AVR, right anterior minute thoracotomy?
Is a question for me or for Lamellas?
It's for you from Lamellas.
Okay. So the scope is surely, if you want to be even less than mini thoracotomy, so if you want to work in a sort of endoscopic approach, you need the scope, and procedure can be performed either with or without. Sometimes you have to move very often the camera because the visualization or the field through the aorta is obviously less, and camera should be adapted and adjusted several times.
I want to ask one very quick question for Michael. Michael, thanks for your presentation. In some ways, we're preaching to the choir regarding minimally invasive surgery. And there's a lot of good retrospective observational data, but there's not a whole lot of prospective randomized data. You know, even looking at upper hemi versus right thoracotomy versus full sternotomy, what's it going to take? Because I assure you, Joe Lamellas is not going to randomize a patient to full sternotomy, and Mattia Glauber probably won't either. So what's going to take for us to do a randomized trial to really figure out what's the best approach?
Thanks a lot, Tom. There have been actually several randomized trials comparing to upper hemisternotomy, not the right anterolateral thoracotomy, but upper hemisternotomy to conventional full sternotomy AVR. We also spearheaded one multi-center randomized trial using the first generation of the intuitive valve. And most of these studies show some benefit with regards to, example, bleeding, that there's less bleeding, shorter ventilation times, but it's not a consistent finding across the trials. And some of the trials are also, several of them are quite old, and I don't think they would sort of stand up to today's scrutiny for the standards that we require for ongoing randomized trials. I would love to see a big multi-center trial, but I share your concern. I would also have a little bit of a hard time randomizing the younger patients in particular that are really asking for this approach and asking for this technology. it behooves us, I think, to try nonetheless to carry on a big randomized trial, but I'm not sure if we'll ever get it done, Tom.
Yeah, thank you, Michael. Well, it looks like that's all the time we have left for the group discussion. Thank you, Dr. Glauber and Borger, for being with us today. And again, to all the presenters in this session, our ISMICS live studio host will be with you in just a moment. Thank you, Marco, for co-moderating with me.